Sir, over to you.
Thank you very much, Sripriya. I just want to make sure that everyone is present. Last time, one of the candidates had said that he had not got the meeting link. Is everyone present this time?
We trust so, sir. Once the meeting is on and going, I will confirm from the back. Dr. Ashok.
Dr. Chandana, Dr. Sanudev is here. Right. Okay. We very much for joining us today again for this lecture. Uh, I'm Dr. Ashok. I'm a consultant medical oncologist at Aster.
Dr. Ashok, sorry, is it only for me that I had lost the connection, or is anyone else able to do that?
Hello, can you hear me now?
Now audible.
Yeah. Dr. Sanidev, Dr. Sanidev wasn't there in the last session. So, if you don't mind, Dr. Sanidev, if you can just introduce yourself, your name, where you're from, where you're working, that would be good. He's an eminent faculty who has a special interest in community palliative care. She did an MD radiotherapy from Government Medical College Thrissur, and now she's working as a senior resident in palliative care in CMC Vellore for the past 2.5 years. Over to you, ma'am, please.
Thank you so much, sir. I think, I hope I am audible. Shall I share my screen?
Yes, please.
A very good evening to all. Today's discussion is on assessment and types of pain. So I'm sure that you had a great session on I'm sorry, pathophysiology of pain in the last week. So we'll continue with the assessment of pain. So without wasting much time, we'll go to the topic. To properly assess and treat pain, it is very important to understand pain as an experience rather than a simple sensation. It is told that pain is not felt by the nerve endings, but by the patients and their families. And also, medical community's understanding of pain has evolved over the years from a sensation that is related to tissue injury all the way to a very complex experience consisting of various causes, contributory factors, and a myriad of emotions. Lately, we have even uh, excuse me, am I audible?
Yes, sir.
Lately, we have even found that for the experience of pain, for the perception of pain, a tissue injury per se is not necessary. So this change in concepts have been has reflected in the change in pain definition over the years. So initially, the pain definition that has been widely used was proposed by IASP, International Association of Study of Pain, in 1979, which was an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. This definition actually held for almost 40 years before it was changed in 2018 to an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So basically, the understanding that pain itself does not need an actual or potential tissue damage to be experienced has has resulted in the change of this definition. And this is something known as the pain matrix. We can see that the various regions of the brain which is associated in the perception of pain, which again points to the complexity of this sensation. On lines of this concept, another concept that was put forward by Dame Cicely Saunders, who is the founder of palliative care, is total pain. I'm sure that you must have already seen this slide, and you will be repeatedly seeing this slide throughout the various presentations on pain. So basically, this concept says that pain does not only has a physical component but also psychological, spiritual, and social components. So all these comes together to express the to form the pain experience that each patient has. So obviously, because of all these reasons, since these factors vary from person to person, pain is a ex- very subjective experience. Often the pain experience may be in out of proportion to the actual perceivable tissue damage, or it may be less than the actual expected pain for that particular tissue damage. So it is very important to keep that in mind when we go for assessment. Pain is very subjective. So to get some context, so this is a graph showing incidence of moderate to severe cancer pain in various stages of cancer. So we can see that pain is a major morbidity in all stages of cancer, starting from 23.8% from stage 1 to 44.2% to stage 4. In all stages combined, around 50% of the patients have had this pain experience at some point of time. And when it comes to advanced cancers, it increases to 70%. And this is data from 2016. Interestingly, this data shows that the pain during the cancer journey is not only limited to before or during treatment. So here we can see that even after curative treatment, 39.3% of the patients had cancer pain. So during cancer treatment, it was 55%. Obviously, in advanced or metastatic cancer, it has increased to 66.4. And among them, 38% of patients had moderate to severe pain. So the next question is there, since we have seen that cancer pain is a major morbidity, so is there a gap in the way that we assess and treat cancer pain? The answer would be yes. So this data from 4 main cancer hospitals in India shows that around in cancer patients with mild pain, around 50% of the patients get inadequate pain relief, which increases to 80% in moderate pain and increases all the way up to 94.3% in severe pain. Again, so the data that I showed you previously in 2016 was actually an update to another data which was published in 2007. So we can see that over this 10 years from 2007 to 2016, actually the prevalence of cancer pain has increased in various stages of cancer treatment, like during treatment, after curative treatment, advanced metastatic cancer. And again, the percentage of moderate to severe pain also has increased. So there may be various reasons for that, but just compare it with the uh, vast majority of advances that had happened in the disease modifying treatment as such during these past 10 years. So we can clearly see that cancer pain has not been in our priority list. So the point of telling all this is that since it is a very prevalent problem throughout all stages of cancer and even after curative treatment of malignancies, all patients with active malignancy should be routinely screened for pain. And again, patients who specifically report pain require a more comprehensive assessment and specific treatment. So coming to the clinical evaluation of pain. So while assessing pain, it is always beneficial to keep the treatment part in mind. So not only for pain, for generally all symptoms in palliative care, the main 3 ideologies of treating a symptom are correct the correctable, non-drug measures, and drugs for symptoms. So obviously, to correct the correctable causes, we'll need to know exactly what is going on. And non-pharmacological measures will comprise of all the other things that we do for the pain, and third one will be drugs for the symptoms. So assessing the pain completely is necessary to treat the pain, because to know the correctable causes we'll need to know the pathophysiology of pain, and same for non-drug measures. And drugs for symptoms also will depend on the type of pain and severity of pain, etc. So keeping this in mind will be helpful in assessing the pain. So what are the aims of our assessment? Why do we assess pain? So basically, by assessing pain, we are trying to understand the characteristics of pain, pathophysiology of pain, etiology of pain, and other factors contributing to the pain experience. So we will go into each of them in detail. So before going to each of the specificities of that assessment, so there are some general principles that we can actually do while assessing pain. So this is basically to get a rapport with the patient. So basically, when we are assessing pain, it is always important to establish a trusting relationship with the patients, because some of them may be very reluctant to express their complaints or express their pain severity. So it is always helpful to have a trusting relationship with the patient. So always we usually try to begin with an open question before going into more specific questions. So open question is something that actually opens the doors to various areas of communication rather than asking how is your pain in your arm. So we can ask how are you feeling today, so that the patient can actually express more, so patient can tell more, and before then we can go into the more specific questions. And always encourage the patient to do most of the talking rather than us lecturing and the patient listening. We should encourage patients to talk more. And again, it is important to watch the patient for visual clues, because in India especially, some of the patients may be not very vocal, or they may be reluctant to report the pain. So always watch for the visual clues. And most important thing is not to assume. So as Dr. Robert Wycross, one of the pioneers in palliative care, says in his book, Introducing Palliative Care, to assume is to make an ass out of you and me. So it's always important to avoid assumptions and avoid jumping into conclusions as far as assessment of pain is concerned. So some other points to help in the communication part of pain. So basically, it is always helpful to introduce ourselves clearly. Maintaining eye contact is important. So all these things are to make patients comfortable and to let them know that we are actually concerned and we are actually listening to them. And it is always important to explain to the patient about what is going on and what is being done. And after all this explanation, it is always good to summarize, because the patients may be going through a lot of emotions, and they may not be able to imbibe everything that we tell them. So in the end, it is always a good practice to summarize what we have already told. And it is always important to avoid patronizing, giving false recurrence and comparison. So I am personally guilty of doing that during my PG days. So whenever some patient complains of severe pain, and if I feel that the patient it is out of proportion, so I just I used to tell the patient that even people with more severe disease than you have more tolerance, and you should actually be more brave and all those things. So comparison is not a good thing as far as assessment or communication is concerned. So patronizing, false reassurance, comparison, everything to be avoided. And it is important to use appropriate language and to avoid medical terms, all those things, so that the patient and the doctor are on the same page. So before going to the proper clinical assessment, I would like to stress on 3 points. The first point would be listen. So I'll just play a brief video clip of again Dame Cicely Saunders, who is the founder of palliative care. It is her advice to everyone who is going into palliative care or going into medical field. So we'll just listen to that. Are you able to hear the sound?
No.
Okay.
No,
Okay.
it's
Yeah.
stuck.
Just a minute. I'll just stop share and again.
You really, I'm often asked, what is the first thing you really want to say to somebody going into medicine or moving into palliative care? What is the major commitment? And I'm sure the answer is simply listen to your patients. They'll tell you. They'll tell you what they need. They'll tell you who they are and what they can achieve.
So simply listening to the patients can give us a lot of info that we may miss otherwise. The second thing, I'll just give you a couple of case scenarios. First is a 54-year-old gentleman. He's a known case of carcinoma lung with bone mets. He comes to you with a pathological factor of fracture of right humerus. Patient grimaces in pain, has tachycardia and sweating. He says that he is in severe pain. Second case is a 60-year-old gentleman. Case of carcinoma head of the pancreas on chemotherapy for the past 4 months. Patient says that he is in severe pain. He does not appear to be in pain though. He looks tired and gloomy and has decreased appetite and sleep. So my question to you is, so which among the following, I mean, which among these two patients are telling the truth? Which among them is actually in severe pain? And Dr. Vinayak has mentioned both, which is very.
You can unmute and okay, participants can unmute and answer at any time.
Both of them.
Yeah, definitely. Exactly the same. So my point is, often in chronic pain, in cancer. So chronic pain is something different from an acute pain. So acute pain is usually body's way of telling that something is going wrong. So it has a physiological function. So in contrast to that, chronic pain is a disease in itself and does not serve any physiological function. So it is usually has an ill-defined onset and a prolonged fluctuating course. And especially in chronic pain, overt pain behaviors like grimacing and sympathetic hyperactivity like tachycardia, sweating, everything is typically absent. But vegetative signs like lassitude, sleep disturbance, anorexia, etc. are present. And patients usually do not appear to be in pain. The only definitive way to determine the presence of pain in chronic pain is to obtain a verbal report from the patient. So the first point was to listen. The second point was to believe. So this is again a quote from Dr. Robert Wycross. Pain is what the patient says hurts. So it is always important to believe the patient on his complaint of pain. So coming to the third principle, general principle is having empathy and compassion. So it will actually increase the patient's. So these things you might, as eminent oncologists, you must all be very aware. But I'm just mentioning. So listen, believe, and have empathy and compassion are the three things that we can keep in mind so that we can assess the pain better. So now I'm going into a checklist that we can all keep in mind while assessing pain. So basically the assessment of pain will include all these steps. The first thing would be a careful history of the pain complaint to place it temporally in the disease history. Assessing the characteristics of each pain, clarifying the temporal aspects of pain, listing and prioritizing each aspect. So temporal aspects basically is the time dependence of the pain. So when did the pain start? When is the pain increasing? When is the pain decreasing? So all those things. Listing and prioritizing each complaint, evaluating response to prior or current analgesics and disease modifying treatment, evaluating the psychological state. Remember the total pain we discussed. So there can be other factors contributing to pain also. Past medical history and addictions, because it is very important when we prescribe drugs for the pain. A careful clinical examination to find anything that is correctable for the patient. Necessary investigation, whatever investigations that we feel that may improve the quality of life or improve the pain experience of the patient, and designing a therapeutic approach based on this. So now we'll go to certain points in detail. So as I mentioned earlier, the primary aim of assessment would be to find out the characteristics of the pain, pathophysiology of the pain or the type of pain. Third would be to find the etiology of pain, and fourth would be to find the other causes of pain, other contributory causes to pain. So coming to the characteristics of pain. So a common mnemonic that we use for characterizing the pain are PQRST. So basically we'll ask for palliative factors or the factors which are actually improving the pain, provocative factors which are actually factors which will actually worsen the pain, quality of pain, the type of pain, whether it is a throbbing pain, aching pain, stabbing pain. So all this will differ according to the type of pain the patient is having. So different types of pain will have different qualities. Radiation, whether the pain is actually going to somewhere else, severity and impact in life, and temporal factor. So the mnemonic is PQRST, but in clinical practice it is easier to go the other way around. TSRQP, first the temporal factors, severity and impact, radiation, quality, provocative factors, and palliative factors. So this is actually, there are multiple mnemonics for that, but this is something that we commonly use. So, another important thing would here is severity and impact of the pain. So one of the main things, because that will actually decide our drug therapy, what medicines that we are actually prescribing the patients. So there are multiple tools for assessing the pain intensity. So those tools can be broadly classified into unidimensional tools and multidimensional tools. So unidimensional tools are basically the tools that assess the pain complaint itself. So how severe is your pain? That is the only thing that we are looking at. So there are various ways of expressing the severity of the pain to the patient. So the only question we are putting to the patient is how severe is the pain. So all these things, the numerical rating scale, faces rating scale, and Bishu analog scale are all those ways to answer this question of how severe is the pain. Second thing would be multidimensional tools or multidimensional questionnaires. So what we essentially do here is we are going to other aspects of the pain also. We are actually detailedly asking about the type of pain, the character of the pain, the impact of pain in various aspects of life, etc. So one example of unidimensional pain scale is the numerical pain rating scale, which is widely used. So this is basically a linear scale from 0 to 10. So the patient is actually asked to, 0 is no pain and 10 is the most severe pain. The patient is asked to give a number, give a rating to his pain. So basically score of 1, 2 and 3 are considered as mild pain, 4, 5, 6 is considered as moderate pain, 7, 8, 9, 10 severe pain. So we can actually, each visit we can ask the patient his pain score so that we can assess the improvement or worsening of the pain and response to our therapy. We can also ask for the worst pain in the past 24 hours, the best pain in the past 24 hours, and the current pain. And an average of this, we can get the average pain for the past day. So that is also another way of doing it. So this is just a numeric pain rating scale. The next would be a visual analog scale. This is actually a way of expressing a continuous entity. So this is there are not certain markings here. So this is just a straight line going from no pain at all to excruciating pain. So the patient is asked to do a marking in in any place of this line. So this is around 10 centimeters long. So if the marking is more towards this side, this is more painful. Obviously, towards this side will be less painful. So each visit, we can actually ask the patient to mark again so that we can actually compare the severity. The next thing would be Wong-Baker Fraser scale. This is actually it was actually primarily developed for pediatric patients where they are having difficulty to express the pain. But now this has been widely used for all sorts of patients. So this is basically a list of faces, and according to the we compare it with the facial expression of the patient, and then according to that we'll actually evaluate the pain of the patient. So 0, 2, 4, 6, basically, as you can see, this is a very common tool that can be used. So coming to the multi-dimensional questionnaire, so this is called McGill Pain Questionnaire, which has actually come out in 1975. So these, as you can see, this is an extensive questionnaire. A shortened form of this is also available. This is a short form of McGill Pain Questionnaire. So you can see that there is multiple sessions asking for that exact character of the pain, and there is also in the original McGill pain questionnaire, so there is also questions that leads to that tries to understand how the pain impacts the patient's day-to-day life also. So this is one example of a multi-dimensional questionnaire. Another thing would be brief pain inventory. So this is the original one which has come out in 1983. So this is a shortened form of brief pain inventory. So here we can actually we have two diagrams where we can mark where the pain is. We can there are questions regarding the worst pain, average pain, current pain, and how the pain affects the general activity, mood, walking ability, and all sorts of things. So how the day-to-day life is affected because of pain. So there are multi-dimensional tools and there are unidimensional tools. So when to use this will be another question. So these multi-dimensional tools are not routinely used in clinical practice because obviously it takes a lot of time, and more importantly, this has to be filled by the patient. So there will be difficulty in communicating all these things to patients, and it may be difficult especially for patients who are uneducated and all those things. So the specific use of this multidimensional questionnaires will be in a study setting, and also when we need to differentiate between suppose the patient is in distress, and if we are doubtful whether it is a physical distress or he has an existential crisis, so then we'll have to differentiate between the distress due to physical symptoms or some other psychological causes. Then this is actually very helpful because there are specific questions to pertaining to effect of pain in various factors of life. So that is one area that this multidimensional questionnaires can be helpful. So obviously not routinely used in clinical practice. So this is another tool which is known as the NCCN distress thermometer. So you may be aware of this. So basically, as we mentioned, pain is not just a sensation; it has a myriad of emotions attached to it. So to assess the total distress of the patient, this is something called NCCN distress thermometer. On the left-hand side, we can see a thermometer where the patient can actually mark his distress, and on the right-hand side, so there are certain questions pertaining to that distress, practical problems, family problems, emotional problems, all those things can be there. So this is another very useful tool in assessing the distress of the patient. So these are the tools that we usually use for assessing the severity of the pain. So a word about temporal factors. So temporal factors basically relates to the relation of pain to the time. So we define pain as acute pain, chronic pain, and all those things. One important thing to keep in mind is that, especially in chronic pain, there are two components of pain that we should be aware about. So one thing is the background pain, which is actually chronically present throughout the day. Second thing would be fluctuations in between or spikes in between, which is known as the breakthrough pain. So that happens in between. So it is always important to assess and address this breakthrough pain which is important while prescribing medications also. So we'll have to give medicines to cover this background pain and SOS medicines to take care of this breakthrough pain also. So while assessing the temporal factors, it is also important to address this background pain and breakthrough pain. So having completed the tools to assess the severity of the pain or the characteristics of the pain, then now we will move to the pathophysiology of the pain, the second aim of our assessment. So pathophysiology of the pain can also be described as a type of pain because pain classification is based on the pathophysiology of pain. So basically, in a very broad sense, pain can be classified as nociceptive and neuropathic. So nociceptive is where there is a tissue injury. Neuropathic is basically there is a nerve injury. It's a very broad way I'm telling, but again, basically it is like that. So again, in nociceptive, it can be divided into somatic and visceral. So somatic would be soft tissue and bone. Visceral would be any internal organs or viscera. So this is the very classification in a nutshell. Nociceptive will be associated with tissue injury. Neuropathic will be associated with nerve injury. So again, we'll go to neuropathic pain first. So neuropathic pain is basically where there is a neoplastic invasion or compression of the spinal cord, nerve roots, plexuses or peripheral nerves. So it can also be due to various other causes like leptomeningeal metastasis, some cranial neuralgias in case of any masses there, paraneoplastic peripheral neuropathies, treatment related like chemotherapy related peripheral neuropathy, radiotherapy related brachial plexopathy, and all those things can be there. So all these comprise of neuropathic pain. It is said that 40% of patients with chronic cancer related pain have a neuropathic pain syndrome. So there is usually some typical description of patients related description by patients of neuropathic pain. So typically this pain is actually described as pins and needle sensation, stabbing pain, burning pain, all those things. And often neuropathic pain can be radiated to other areas also. So this is about neuropathic pain. So basically there is actually even a diagnostic criteria for neuropathic pain. So one example would be one diagnostic tools for identifying neuropathic pain. So the one most commonly used would be the DN4 questionnaire. So basically all neuropathic pain questionnaires or neuropathic pain identification tools rely on some basic things. So first thing would be the description of the patient. Usually the description of the patient would be burning, some sensation like cold and heat is painful, electric shock like sensation and all those things, tingling, pins and needles, numbness, itching, all those things would be the description. Second thing would be some clinical signs. First is hypoesthesia of that particular region, hypoesthesia to touch or pinprick. Two other things would be allodynia and hyperalgesia. So allodynia is basically a perception of a non-painful stimulus as a painful stimulus. Suppose if you brush there, the patient will perceive pain. Hyperalgesia is increased sensitivity to pain, or normally a stimulus that can cause only a mild pain will be perceived as a severe pain. So basically all this neuropathic pain tools take all these factors into account. So the description of the patient and the clinical signs like hyperesthesia, allodynia and hyperalgesia. So this is one example of a neuropathic pain questionnaire. So there is another type of neuropathic pain known as the sympathetically mediated pain, especially seen in chronic neuropathic pain conditions, which is usually rare in cancer patients, but it is important to keep in mind. So basically what happens in sympathetically mediated pain is there is an abnormal coupling between sympathetic efferent and nociceptive afferent neuron. So the pain of a particular region. So I'm not mentioning about the general sympathetic activity that can be seen in acute pain. This is pertaining to a particular region. So the afferent neurons, nociceptors from a particular region is abnormally uh, coupled with sympathetic efferents to that particular region. So in addition to the neuropathic pain, so there are also some vasomotor or pseudomotor symptoms also. So basically in that area, there may be sensory symptoms. So basically like hyperesthesia, allodynia as in any neuropathic pain. Along with that, there may be vasomotor and pseudomotor symptoms. Vasomotor symptoms like temperature asymmetry, skin color changes, skin color asymmetry, etc. Pseudomotor edema like edema, sweating changes, sweating asymmetry, etc. can be present. So this is sympathetically mediated pain. This is one of the important contributory mechanisms of various other causes of conditions of pain like complex regional pain syndrome. One of the causes of complex regional pain syndrome is sympathetically mediated pain. So basically there is an abnormal coupling between sympathetic efferent and nociceptive efferent neurons. So the neuropathic symptoms of pain is associated with vasomotor and pseudomotor edema. So obviously the diagnostic criteria of this, the diagnosis will be of this sympathetically mediated pain will be presence of neuropathic pain along with vasomotor and pseudomotor symptoms. So now coming to nociceptive pain. So nociceptive pain is basically associated with a tissue injury. So it can be either from soft tissue or a bone. which is somatic, and next thing would be viscera. So any abdominal hollow viscous or any pain sensitive peritoneal covering like parietal peritoneum, all those things will come under nociceptive pain. One, the category would be visceral. So visceral pain and somatic pain. Somatic pain will include soft tissue and bone. So the description usually varies. Somatic pain is usually described as aching, throbbing, dull pain when a soft tissue or bone is affected. And even in that, bone pain has some definite specific characteristic. So the exact mechanism of conversion of a painless bone metastasis to a painful bone metastasis is unknown. But once it is established, so there is a definite neuropathic component to bone pain. So basically, bone pain occurs because of direct invasion, secondary pathological fracture, or damage to the adjacent structures. So it has actually both inflammatory and neuropathic component. The neuropathic component can be due to the direct nerve injury because of the disease or and consequent pathological sprouting of sensory and sympathetic nerve fibers there in response to the injury. And all these neural changes, and there is also some perineural release of growth factors due to the tumor and also some chemical mediators. And again, there is mechanical distortion related to the microfracture. All these things will contribute to bone pain. So bone pain will usually have an inflammatory and neuropathic component. So again, they have actually proposed a diagnostic criteria for bone pain itself. So basically, it includes we should have an evidence of a metastatic bone cancer and presence of continuous background dull pain there should be there, and there should be some evoked spontaneous pain with I mean, like if we press there should be some pain and all those things, which in areas which are corresponding to the bone met, and hyperalgesia, hyposthesia, and neuropathic features of pain should also be present. So this is something that we don't use very much in clinical practice for differentiating bone pain, but just keep in mind that usually bone pain will also have a neuropathic component, the mechanism of which we discussed in the previous slide. So coming to visceral pain. So visceral pain can be either because of obstruction of any hollow viscous or any other pain sensitive visceral structures like visceral pleura, hepatic capsule, or peritoneum. It can also be treatment related. So especially after a surgery, if the patient develops some adhesions and all those things, it can also cause visceral pain. So obstruction of hollow viscous will usually be described as colicky pain, twisting pain, cramping pain, etc. Especially seen in intestinal obstruction or chronic intestinal obstruction, especially in gastrointestinal malignancies. And pain sensitive visceral structures like visceral pleura, hepatic capsule, etc. is not exactly colicky and twisting pain. So as we all know, hepatic metastasis, liver metastasis, or primary hepatoma can stretch the liver capsule, which is all usually described as a dull aching pain in the right hypochondrium. So if the patient, if the stretching is on the superior surface, there can also be referred pain to the ipsilateral shoulder, and like hepatic capsule pain, and porta hepatis, another pain sensitive structure. If it is stretched, there can be a dull aching pain which can actually radiate to the lower end of the scapula. So all those things comprise of visceral pain. So when a hollow viscous is involved, it is typically described as colicky twisting pain. So that is pathophysiology of pain, which is also a type of pain, as pain is classified based on pathophysiology. Now coming to the etiology of pain. So the important thing to mention that, so the important thing to keep in mind is that whenever a cancer patient comes with pain, so it is always important to open our mind to various other causes of pain also. So all pains in cancer patients are not due to cancer itself. So these are the things that usually cause pain in cancer. It can be because of the disease, like soft tissue, bone, nerve, viscera, as we mentioned earlier. It can be treatment related, like chemotherapy related neuropathy, RT, chemo-induced mucositis, etc. It can be because of other debilities like constipation, muscle spasm, other concurrent disorders like osteoarthritis or diabetic neuropathy. All these things can be causes of pain. So we have to keep an open mind to all these to find any correctable cause so that we can improve the pain of the patient. And another important factor to consider is that even in advanced cancer, it is said that in 15% of the patients, none of their pain is actually caused by the cancer itself, even in advanced cancer. So it is always important to keep an open mind to various other causes of cancer also. So now that we have completed pathophysiology, etiology, and assess characters of pain, what are the barriers of pain assessment? So usually it can be from the patient side and from the physician side. So barriers to a pain assessment from the patient side would be reluctance to report pain, fear of injections and medications, believe that the pain is an inevitable consequence and must be accepted. So this is something again that I was guilty of doing in my PG days. So I obviously had no idea about the principles of pain management. So whenever a patient comes to me with pain, I will prescribe whatever analgesic I was aware of. And if the pain is not controlled, the thing that I usually used to tell the patient is, this is because of the disease. There may be some pain. It will improve as the disease uh, improve. So that is even I mean, I used to believe that some pain should be there during this disease process, and some patients also believe that this is a part and parcel of the treatment. So we should just keep it in mind, and especially it will be significantly difficult in cognitively impaired patients and elderly and pediatric patients where they will not be able to communicate pain very effectively. So these are the barriers from patient side. So from physician side, the question is, do we really underestimate pain? The answer would be yes. See, there are I just quoted two studies. So Grossman et al. Has found that when patients rate their pain as moderate to severe, oncology fellows fail to appreciate severity in 73% of the cases in moderate to severe pain. And another ECOG survey shows that discrepancy between patient and physician evaluation of severity of pain is a major factor in inadequate relief. So we do underestimate pain. This interestingly happens even in a palliative care setting. So we can see in the study, which was taken in a hospice center, where the primary aim is to keep the patient pain-free and comfortable. Pain was underestimated in 46% of the patients, where it was overestimated only in 28% of the patients. And half of this underestimation was clinically meaningful. So, and again, for patients with a numerical rating score of more than 7 or more severe pain underestimation was both clinically and statistically significant. So we do underestimate pain. So it is actually natural to creep in to our practice, because all of you have been practicing. I mean, all of us. I mean, especially you people have been seeing thousands of cases of various cancers, various stages. So it is usually a tendency to compare. I mean, usually a tendency to relate a particular intensity of pain to a particular stage of the disease. So if this is stage 1, so this much pain is normal. So anything above that we may underestimate. So we may see it as an exaggeration. But having this in context, so always, as we mentioned earlier, believe the patient, and self-report is the best report. Always keep in mind. So other physician-related barriers would be lack of proper communication. So when the patient is not able to understand what we are conveying, failure to use validated pain measurement tools so that we fail to quantify the pain, and lack of time committed to pain as a priority. So again, another important thing. So another thing I would like to stress is we can always use help. So as we mentioned, so there can be other psychological, social, all causes of factors which are contributing to pain. So when the service of a clinical psychologist or a social worker is available, or a nurse is available, so always please feel free to use help, so that they will be able to give a new perspective or a new set of eyes or a new dimension to that pain experience in this case. So it's always important to use help. So one more thing I wanted to stress before winding up is that, see, you have, I mean, we have all must have all gone through the situation. So even if we are listening to an excellent lecture by an eminent faculty, so if we have a throbbing headache, how much can we actually take in? So when a patient comes to us with severe pain, so before anything else, we must actually give something for that severe pain then and there. Otherwise, all the questions that we ask, all the information that we give to the patient, all those things, it may be futile. The communication may fail eventually. So if some patients come to you with a severe pain, before anything else, give something for that pain so that the patient's discomfort comes down and a proper communication assessment is possible. So I'll just give a brief introduction to adjuvants also. So basically this is the pain pathway. So you must have already come across in the previous lecture. So basically from the site of tissue damage, the afferent nerves will take the signals to the dorsal horn of the spinal cord, which is then through the ascending spinothalamic tract conveyed to the thalamus and then to the various parts of the brain. From there, descending tracts will down regulate the pain. So basically the analgesics that we give can be broadly classified as those group of analgesics which inhibit the ascending pain transmission, and another set of analgesics which facilitate descending pain modulation. The inhibition of ascending pain transmission is by our typical analgesics like acetaminophen, NSAIDs, opioids, ketamine, local anesthetics, etc. Or some of these drugs can have an effect on facilitating descending pain modulation also. But descending pain modulation is primarily by adjuvants, anti-epileptics, antidepressants, etc. So basically, the tools we have for pain relief, the pharmacological tools we have for pain relief can be broadly classified as analgesics and adjuvants. Analgesics are typical pain medications that we are all aware of. So adjuvants are not typical pain medications, but in certain circumstances and when used in conjunction with adjuvants, so analgesics, it can actually improve the pain of the patient. So this is a broad, just an overview regarding the various adjuvants that we commonly use. So steroids we very commonly used for pain, especially by inflammation and edema. Antidepressants and anticonvulsants, especially useful in neuropathic pain. So this is one of the important reasons to differentiate between somatic pain and neuropathic pain. So I also wanted to convey one more thing, that there can be a mixture of pain also. It need not be always like the pain is either somatic or neuropathic. There can be a mixture of both. So it is important to identify the somatic as well as neuropathic component, because neuropathic component, yes, at 30% of the cases, neuropathic pain also responds to opioids, but in certain cases, definitely we'll have to add some adjuvants like antidepressants and anticonvulsants to control the neuropathic pain. You will obviously go to all these in details in the coming session. This is just to give an overview. So antispasmodics can be given in bowel colic, antibiotics can be given in concurrent infection, and sedatives. If the patient has severe pain and if you want to sedate the patient, then that can also be done. So these are about adjuvants. So that is, I think I am on time. So that ends today's presentation. Thank you.
Thank you very much, Dr. Jewell, for that excellent presentation. Before I open the session to questions, I just wanted to confirm with you all if you have received the previous class, the previous session's material. I hope all of you have received it. If anybody has any issues with that, please do contact Pallium India for that. We will send it over to you. Before we start, Dr. Jewell, I'd like to ask one of my own questions. You had mentioned many pain scales. You have the visual analog scale, the numbered scale, and the phases. What would you prefer in a setting of palliative care for your patients, adult patients?
So in our setting, we usually use the numerical scale. So that will be very easy. So if the patient has some baseline education, it will be very easy too. So what we usually do is we have a scale with us with the numbers. So we'll just show the patient regarding these things and ask them to give a number. So they usually do well. So in pediatric patients, obviously, face a scale we use.
I'm opening the session to questions. If anybody has any questions, you can ask Dr. Jewell, or you can put in the chat box. I think you have been so crystal clear that nobody has any doubts. Everybody is totally, completely studied your topic. Dr. Jewell had also mentioned about a small introduction to the medications also. We'll be going to that in detail from session 4 onwards. There'll be an introduction to the WHO ladder. And after that, there'll be the concept of adjuvant and analgesics and opioids and so on. The next class will be about communication. So if you notice how we have kept the sessions, there was an introduction, now there is an assessment. This is basically how we should be proceeding with our patients also. So the next topic is about communication, because I feel the take-home point that I got from when I entered into this course was that in pain control and pain palliative management, the most important is communication. Everything else comes after that. Any medication you give, anything you do will not compare to a good communication with your patient. So that's why we are going in this order, and you'll be reaching only the drugs by session 4. So for completion's sake, I'm going to ask once more if there's anybody else who has any doubts to clarify with Dr. Jewell. Dr. Sanidev, he's asked, how often will you reassess pain to modify the medications?
I think that would be discussed in actually when the medicines. I'll just tell that when we give opioids and all those things, we usually have certain criteria. So basically, the idea would be this will probably be covered in the opioid session. So basically, when we give a drug, an opioid, so we usually wait for 5 or 6 half-lives of the drug to attain a steady state level, and then we usually reassess the patient. It will be approximately like 72 hours or 3 or 4 days after that. But that will be again dealt in detail with when the pharmacological management is discussed, I think. So assessment is only review will only come after treatment. So other than that, there is no point. So review will be an important part of the discussion, I hope.
Yeah. Since I've already attended the session last year, I can tell you the answer to that. Basically, yeah, like you said, it will be there in opioids, the session on opioids. So we will reassess around 48 to 72 hours. That is what was taught to me last time. And after that, we have to increase or decrease the medication as required. At that time, there'll be a lot of assessments as on how many rescue doses were taken, what is the level of pain control, what is the percentage of pain. Those things will be discussed in detail in the opioid session.
So one thing to add is that in severe pain, we need not actually wait for 72 hours. Yeah. So we can reassess the next day itself. But that will again, as a general guideline, 48 to 72 hours is when we reassess usually.
I have one question. Thank you, Dr. Jewell, for an excellent presentation. I just have a question in that assessment slide, no? That PQRST. You mentioned whether we should go from the from PQRST or it's from TQ. Means it's in the reverse way. There has been something mentioned in that slide. I didn't get it actually properly. Okay. Can we have the same slide again?
Yes, please, sir. Please, ma'am. I'll just see. You want that PQRST slide, no, ma'am?
Yeah.
Just a minute.
Yeah, and this is the one. So
sorry. Yeah, tell me, ma'am.
Whether the order should be PQRST or TSRQP. So you mentioned no, but
yes, ma'am.
You should go, but
yes, ma'am. PQRST is just as easier to remember as a mnemonic. But when we usually ask the patient, first thing we'll ask is when did the pain start? What is the severity? Does it go anywhere else? What is the quality?
Usually go.
Yes. Way. So just to remember it in an easy way, we'll just mention PQRST, but we go the other way around usually.
Okay. Thank you.
Right. Is there any other questions? Right. So I'd like to thank Dr. Jewell once more for that excellent presentation. I think it was quite lucid and there aren't many doubts around. So thank you very much again, Dr. Jewell. Thank you so much for taking the session.